Good evening, friends. Today we are having again an online session due to this COVID wave. Without wasting much time, I'll invite hand over to our moderators, Dr. Sucheta Ben and Dr. Ruchir, for further taking up the proceedings. Sucheta Ben and Ruchir.
Good evening, everybody. Welcome to all of you online this time. Not meeting. I missed meeting you all on first. Because my son was not well, so did not come there. So today's topic is very interesting. We have been discussing about ring enhancing lesions, single lesions, multiple lesions since when I was a student. Since that time, once the CT scan and then MRI came, since then we have been having this mystery whether this is the tuberculosis, cysticercus, any other thing, and now we have got these mnemonics, Dr. Magical and whatnot. So we have a very good speaker today, Dr. Sagar Betai, to talk about this and throw some light on all these various lesions and possibilities about ring lesions. Dr. Sagar, he is a alumni of SGPGI, and after that he has done a lot of work in infections of neuro-infections rather. So I'll just hand it over to Sagar. Welcome, Sagar, and you can start your speech.
Thank you and good evening, madam, and good evening to all dear seniors and friends. Right, I'll just share my screen. Yeah, is my screen visible?
Yes.
Right. Yes. So, madam, as you said, I mean, it's a very intriguing subject. It was very difficult for me to even, study and dissect out of all the various causes, including infections and non-infectious diseases. So it was a learning for myself as well in the process of preparing the talk. So the reason why I chose this topic, because every time we face this hurdle, whenever we have a single large lesion or multiple small lesions, which are ring enhancing, it is sometimes very difficult dilemma. Is it an infection or some malignancy or demyelination sometimes? And what infection it is, because the brain obviously not an easy place to biopsy. And the CSF study also is sometimes non-yielding because there is no sort of meningitis along with that parenchymal lesion involvement. So for all these dilemmas, I try to attempt to tease out the possible ways how we can approach, what are the specific points where the radiology can help, and which are the places where the radiology has its limitations. So we need to understand where radiology can help, where it cannot help, so that we are more clear in even doing an empirical treatment based on probabilistic diagnosis when we don't have obviously a microbiological confirmation. In the process, I also realized that there are no unified guideline or a way of approach, even in neurological or in the radiological textbooks as well, which unifies all the causes of infections and non-infectious ring enhancing lesions. So before actually I come over to ring enhancing lesions, I would try to give a message that the focal enhancing lesions are one of the patterns. I'm right now talking mainly about the CNS infections and the patterns of CNS infection which are lookalike when caused by non-infectious lesion as well. So the CNS infections can be ring enhancing. Another pattern can be a leptomeningitis-like pattern. One is a cerebritis-like pattern. A cerebritis we would call an early phase of developing abscess, which may later result in a large single abscess or multiple brain abscesses. The message I'm trying to give right now is that every pattern, if we can recognize, which is the predominant or an early to start with pattern, eventually can be overlap between all these patterns. But if you can recognize an early and a predominant pattern, a few organisms are responsible for a specific patterns and few are less likely in these few patterns. So, for example, when you have leptomeningitis, of course, we don't consider herpes encephalitis as a primary diagnosis. So, in a similar way, cerebritis would have bacteria and fungi as the most common causes. Even the tuberculosis sometimes can start as cerebritis and later on organize into granulomas. The pattern, just a minute. Yeah, this is very interesting. I mean, the cerebritis would have a vasogenic and interstitial edema mainly, while a diffusion restricting cytotoxic edema, what we commonly see in the most of the viral encephalitis, right? So where we don't see apparent so much of edema because it's more of cytotoxic edema only, and hence it is only diffusion restricting and hyperintensity on flare, but not so much of the common term edema that we know of as in the form of vasogenic and the interstitial ones. So the common causes are viral, as I said, autoimmune encephalitis and paraneoplastic encephalitis would have a pattern of commonly cortical gray matter involvement, sometimes deep gray matter involvement in the form of, say, in JE, sometimes CJD. So we know that a few of these viruses, in fact, commonly the viruses would cause a diffusion restricting only cytotoxic edema to start with at least, and eventually less so of the interstitial edema. On the reverse side, some viruses have more affinity for white matter, including CMV. Of course, with ventriculitis, it can cause deep white matter involvement. HIV encephalitis itself, PML, and SSP have predilection to at least start with as predominantly white matter diseases in the category of infections. And a few organisms would have predilection for vasculopathy, in which we have TB, Aspergillus, mucor, zoster, syphilis, endocarditis, and the list is obviously longer, but I've just mentioned the common ones. So now we come to ring enhancing lesions, recognizing the first thing as this pattern, and we'll discuss the details. So very difficult to categorize clearly as textbook pictures, but I think we would better start with large lesions and small lesions. By large lesions, I mean something like which seems like a typical abscess or abscess-like lesions, and a small lesion would be generally less than 1 to 2 centimeters as per the radiology textbooks. The conventionally, arbitrarily demarcated 1 to 2 centimeters as small, and they are generally multiple. So the pattern recognized in large lesions, which are sometimes single, sometimes can be multiple, is in the form of abscess. Commonly would have bacterial abscess, sometimes fungal, and even we are surprised to have mycobacteria, tuberculosis finding in the stain when we have an aspirate of the abscess without even any associated tuberculoma or meningitis. The localites of a brain abscess can sometimes, in the early stages especially, can be GBM, metastasis if they are single or a few larger lesions. Sometimes tumefactive demyelination can have a ring enhancing pattern. Again, a monophasic, subacute course, similar common clinical features, not so much to differentiate from a brain abscess. And in the smaller lesions, I have tried to categorize it in 2 ways. And of course, these smaller lesions we have to keep in mind can eventually become larger ones. So this is not something like written in stone, but at least we can approach a single large lesion or multiple small lesions. In a normal healthy person, we would first think of TB, neurocirrhosis, sometimes even cryptococcal or nocardia or many other fungal lesions can also present in immunocompetent. But the common ones we start with is TB and NCC. An early malignancy, early metastasis can be small, can be single or multiple. Even demyelination form of ADM, because it is a monophasic illness seeming like an infection sometimes. And in immunocompromised patients, specifically we think of cryptococcosis, sometimes nocardia, toxoplasmosis, and uncommonly histoplasma and brucella as well. TB, of course, still remains a contender even in the compromised patients. And in malignancy, lymphoma. Reason being that in compromised patients, it would have more of a ring enhancing like pattern compared to a solid enhancing pattern, which is more easy to recognize in immunocompetent patients. So this lymphoma, in especially HIV, would be more of ring enhancing like rather than solid like, so difficult to diagnose sometimes. So how would we describe a lesion? So if we consider all the following points, we would not miss the pattern, at least in description in our head, and hence we can categorize more easily. So the number and size I already mentioned. Wall characteristics are to be described. The content, how it seems on different sequences of the MRI. How much is the surrounding edema? Halaki, edema is a softer point compared to the other ones, because I mean there can be profuse vasogenic edema even in bacterial abscess. So it doesn't always mean that it's a metastasis or malignancy. Location sometimes can be helpful. We will discuss now further. And associated features can be sometimes very useful if there is a contiguous leptomeningitis from where the source of the infection has come, associated vasculitis. For example, if I have a single large brain abscess, so I would not consider bacteria as the cause if I have associated vasculitis along with that. Maybe fungal would be more likely to start with. The contiguous with paraneoplastic sinus, the paranasal sinuses or middle ear, it's more likely to be bacterial or fungal as the cause. The skull-based osteomyelitis sometimes. And the systemic features, of course, are to be seen, which I would not be discussing right now because I will be mainly focusing on the radiology part and not on the other evaluation which we can do in these patients. So starting with the typical single or a few large ring enhancing lesions, first I'll discuss specifications of the common causes, and then we will compare in brief about the lookalikes. So before radiology, we need to in brief see that the pathology evolves like cerebritis into an abscess, because that's how we can differentiate the different stages of a brain abscess while it's developing. So to start with, it starts as early cerebritis. If it is hematogenous spread, it is multiple ones at the gray-white junction. And if it is starting from a PNS or middle ear, of course, it would be localized in frontal or temporal lobe. Starts with neutrophilic infiltration. The blood-brain barrier so far is relatively intact. Only a mild vasogenic edema is there to start with. And the diffusion of the water molecules across the cells is quite fine. So the early stage, we do not see so much of diffusion restriction, which literally means the blockage to the transfer of the water molecules across the cell membranes. So only then we have diffusion restriction, right? So wherever there is pus, we need to remember this diffusion is impaired, and hence we would have more diffusion restriction. And whenever, because I mean it's very thick, proteinaceous, and the water molecules don't transfer so well. And otherwise, when there is no significant pus, it's only cellularity. The water molecules are easy to transfer across the membrane, and hence there's less of diffusion restriction. As the cerebritis progresses, the macrophages take over, and there starts the central necrosis and liquefaction of that place, and the edema increases. Even the perilesional edema and the edema inside the lesion increases. And last is the encapsulation stage in the form of abscess, where there is a frank liquefaction. The cavity from solid starts becoming liquid, and there is fibrotic capsule, and the inflammatory response of the body and the brain takes over and circumscribes and halts the progression of the infection. So it describes the first stage, the T2 sequence, where you can see, I mean, it starts actually from the frontal sinus, and in the T2 weighted image, there is mild edema in the frontal lobe, more of a vasogenic and interstitial edema. On contrast, we can get a clue that there is developing subdural empyema and contrast enhancement of the meninges here, but there is no enhancement inside this lesion, right? Because the blood-brain barrier is not so much breached at that point of time, and there is inhomogeneous diffusion restriction at that point of time, because the water molecules can transfer well across the cells. And as the brain abscess develops, which takes in average, 2 to 4 weeks, depending on the organism and the immune status, once the abscess is formed, a typical abscess would have a relatively thin wall. We are comparing with right now malignancy, fungal, and TB abscesses, so relatively a thinner wall, which is typically more prominent on the ventricular surface compared to the cortical surface, because of general increase in vascularity on the ventricular side, right? So it is thicker on the medial side, and always, it is thinner on the lateral side, and hence may be more perfused, more vascular, more fragile, and hence maybe it has tendency to rupture in the ventricles. Main characteristic, how we would differentiate bacterial abscess from other abscesses, is that if we have a book picture of a uniform diffusion restriction across the cavity, it's more likely to be bacterial compared to fungal, and equally would have low ADC, and hence it confirms that this is not just the T2 shine through effect. And also on T2 films, because there is a liquid pus, and liquid always would be hyper intense on T2, due to the liquidity, we would have T2 hyperintensity just near the intensity of the CSF. So, of course, lesser than that because of the protein material, but it would be hyper compared to rest of the brain, basically. So these are the common features of a bacterial abscess. We will later see the other causes. Very important clue we should never miss out. We should see the surroundings of the brain to get a clue where the infection comes from. If it is multiple gray white junction, more of hematogenous. If it is localized, we should look for local meningitis, cerebral empyema, as in this case. Very important, skull-based osteomyelitis, which I think is more of a hallmark in bacterial and fungal, more in fungal. And this is one point where we can differentiate it from a tubercular brain abscess, because not commonly TB causes osteomyelitis of the skull base. Sometimes it does, but more of hallmark of a fungal or a bacterial one. And location depends on, as I said, on the source of the infection. So now let's compare vis-a-vis a fungal abscess. So it also goes through cerebritis state, which is the same. I would not repeat it. The walls again are thin, not much to differentiate from a bacterial abscess in a contrast weighted image. In the wall, one specific characteristic would be on the SWI or a GRE image, due to the paramagnetic material in the fungal cavity wall, including iron, we would have a significant blooming in the rim. And if we can find this, even if an incomplete ring, need not be a complete ring would be blooming. This is relatively specific for a fungal infection. So this clue we should always try and look for. On T2, the wall would be hypo and the content would be hyper on T2. So nothing much to differentiate. Another important sequence would be DWI for the fungal one. As I mentioned, that if there is a frank liquefied pus, it would be uniformly T2, diffusion restricting the cavity I'm talking about. But in fungal, a typical fungal abscess, we would have a peripheral restriction because the activity is more in the periphery, and the center does not have so much of the fungal load. Inside this also, Dr. Rakesh Gupta, who was ex-HOD of SGPGI, in fact, of radiology, he had a great emphasis on this projection into the fungal wall, in the fungal cavity. These projections are diffusion restricting, correspondingly low on ADC, and they actually constitute the hyphae projecting inside the cavity. So this is not a random. this is quite a specific sign. As he describes, it has 100% specificity for fungal brain abscess compared to bacterial or tubercular in his own study of 110 patients. Total number of patients. 8 out of 8 which had this sign had fungal abscess. So I think we should always try and look for such signs. To reiterate, because it's important, it would be, even the projection would be diffusion restricting, and the projection would be again correspondingly low on ADC. It would not be contrast enhancing because there is no vascularity inside this projection. So 3 things for fungal. SWI shows blooming of the wall. Diffusion restriction only in the periphery compared to the center. And sometimes, uncommonly, the projection, if can be seen, it can clinch the diagnosis. And again, associated features, we obviously look for the source and associated infarcts. Sometimes hemorrhagic infarcts, because say vis-a-vis tuberculosis, which are more of actually only pure ischemic infarcts, fungus would be more likely to have hemorrhagic infarcts. So coming to the third common cause, which is the tubercular abscess. So before I can discuss tubercular abscess, we will just briefly go through the stages of tubercular granuloma, which we popularly known as tuberculoma, and how it evolves into a TB abscess. So I would not want to confuse everyone with overload of pathological information, but we need to understand for the reason that the radiology would be very much reflecting the pathology. So first is the stage of a small non-caseating granuloma. That's how it starts. There is vascularity throughout the granuloma at this stage because there is no central necrosis. It evolves then into a caseating granuloma. This is a different type of necrosis. In bacteria, we have liquefied necrosis, and in TB, we have caseating necrosis. So caseating necrosis is full of lipid content and consists of macrophages and giant cells rather than the neutrophils. And this stage also is a solid state as the first one, and eventually the caseating granuloma have central liquefaction. So this liquefaction clears out the bacilli from the center. They're only in the periphery, and it has fibrotic rim, which now limits the growth of the tuberculoma. But sometimes they conglomerate and form into an abscess. Commonly, we have these 3 stages that we see, and a brain abscess, TB abscess, need not have associated tuberculomas. It may have, it may not have. It's very variable, so it can still be confused with the bacterial abscess. So whenever it forms an abscess, it is generally of size 2 to 3 centimeter or more, and then the pus is frank in the center. So we are going from solid stage to liquid stage, like in all other abscesses. Just to contrast this from NCC, for example, NCC goes from a liquid stage, a vesicular stage, to the solid stage, and this one goes from solid to liquid, like other abscesses. So, and sometimes, after treatment, it resolves into calcified granuloma, or sometimes it just disappears, right? So these are the stages. We need to sometimes operate and remove the abscess cavity if it is on the surface, or you can just aspirate serotactically in case of a TB abscess. That's the implication of diagnosing an abscess compared to just a tuberculoma. So this we are talking about the smaller lesion right now, because the granulomas are smaller. But before I could come to a larger TB abscess, I wanted to discuss the smaller granulomas first. So first step first, we would try to differentiate the stages of the TB granulomas. The reason being that specific stages can be confused with, say, NCC. A few stages can be confused with bacterial abscess. So we need to know what are the stages. So, T2 and T1 contrast are the main sequences that we look for, because these can help differentiate the ones. The non-caseating granuloma is hyperintense, like most of the I'm talking about the cavity. So cavity of a non-caseating granuloma would be hyperintense, like most of other smaller granulomas, the cagitating granuloma would have very increased cellularity, and hence this high cellularity causes T2 hypointensity. And it's very uncommon finding. The center of the granuloma, if it is hypointense, it can differentiate it from fungal granuloma and NCC and many other causes, because a T2 hypointensity is not a common finding to have unless you have calcification or hemorrhage, which can be T2 hypointense, otherwise, which are easy to diagnose. But otherwise, if you have a simple granuloma, T2 hypointensity is a good, reasonably specific sign for a cagitating granuloma. So not much on flare, because these are not very, fluid lesions, and hence there would no significant suppression. It would not be diffusion restricting, except, as I said, pus is restricting, and just formation of the pus in the last stage. So, and hence it may have mild diffusion restriction, but not of the intensity of an abscess. And as I said, there is no necrosis in the center. It has uniform vascularity, and hence, on contrast, the first stage, which is a non-cagitating granuloma, would have homogeneous enhancement, and hence a nodular pattern, disc or solid enhancement, rather than a ring enhancement. The second stage, the cagitating granuloma, would have generally a ring enhancing pattern, and which is the same as the cagitating granuloma with central liquefaction, because both the stages, the necrosis starts in the center, and hence it's a ring enhancing lesion. So looking at the pictures of the same thing that I said, this is a typical non-cagitating granuloma on flare image, right? This is T2 hyperintense as well as in the flare. No diffusion restriction, and the same corresponding image would have a contrast enhancement, which is in the pattern of a nodular enhancement, because they are smaller lesions as well. Even the larger lesions would have disc enhancement, solid enhancement when they are non-cagitating. The second stage, see, this is what I'm talking about. If it is T2 hypointense compared to the surrounding parenchyma, so this would be reasonably going in favor of a tuberculoma in the cagitating granuloma stage. And the same thing would show typical matted lesions on contrast, because contrast, but otherwise would not, lead to any better differentiation. But this T2 hypointensity can. The third stage, there is central liquefaction, pus formation, and as pus is more of a fluid than solid, it would be brightly hyperintense center on a T2 weighted image with T2 hypointense wall. And same thing showing contrast enhancement as well. So these were the small tuberculomas. The larger tubercular abscess I've directly compared here vis-a-vis the bacterial and the fungal abscesses. So by and large, the single message is that it's easy to differentiate fungal from a non-fungal source and a cause for when we have an abscess. And it's easy to say that it is a brain abscess and not a malignancy or a tumefactive demyelination, which I will discuss in the coming slides. But you can say it's a brain abscess. You can say it is either a fungal abscess or a non-fungal abscess. It's difficult to say if it's a bacterial abscess or a tubercular abscess. So this is the limitation and the benefit of MRI, which we should keep in mind. The wall has nothing much to differentiate because sometimes it can be smooth, sometimes it can be lobulated but smooth, sometimes it can be crenated. So not much to offer in the wall. The content, commonly, as I said, we would have a diffusion restriction in a homogeneous way throughout the cavity in a bacterial abscess, which is only in 50% times. 50% times it would be heterogeneously diffusion restricting throughout the cavity, right? but it is still different from the pattern of peripheral diffusion restriction only, right? I hope this makes sense, that it can be homogeneous or heterogeneous, but throughout the cavity in bacterial and tubercular, and it is commonly only peripheral restricting in case of a fungal abscess. So what are the specific features? As I said, we look for the blooming ring on SWI in a fungal case. If we find the diffusion restricting projection, it is more of fungal. This is more of an observation rather than evidence-based, that conglomerate smaller lesions are more likely to be tubercular, but I mean, this is just a soft point and we can't overinterpret this. Associated feature, always we should look for contiguous infection, same bacterial, same in fungal. Not so common in TB because obviously it doesn't come from the paranasal sinuses or the ear. It comes from the hematogenous source. The fungal, specifically we look for skull-based osteomyelitis, which can suggest more so compared to in case of TB. And MR spectroscopy, again, I would not try and interpret it so much because it is inconsistent in its evidence for its utility in differentiating the cause of the abscesses. But conventional teaching says that amino acid peak more in bacterial, lipid lactate peak. This is my mistake actually. Trehalose comes in fungal and lipid lactate comes in tubercular abscesses. But it's very inconsistent. I have seen so many case studies, and even I'm sure everyone has seen lipid lactate peak comes in even in metastasis or sometimes the fungal and bacterial abscesses as well. So it's not of great utility. It can just be supportive for increasing the probability if it goes in sync with the other textbook pictures in other sequences of the MRI. So this was about the large lesions and infection as their cause. Just brief mention of tumefactive demyelination. Reason I'm discussing only tumefactive is that it can cause a large ring enhancing lesion. It can have a monophasic course, maybe part of Adam, sometimes MOG or sometimes separately, but may have focal deficits, seizures, altered sensorium, and a mild inflammatory picture on CSF, which can be very non-specific and not so differentiating from other causes. So then, how do we differentiate it from the other causes? It may have single or multiple RELs, but at least one of the rings, if it is incomplete on contrast image, it is a very specific sign that it's a demyelination rather than any other pathology, including brain abscess or malignancy. So at least one of the lesions, if you can show that it has incomplete ring on contrast image, it would be a handy thing for differentiating as the pathology being the demyelination. There would not be much to differentiate in the way of the otherwise the wall characteristics. It would be T2 hyperintense. Another thing that it commonly demyelination is in different stages of its development, and hence sometimes it may be some lesions may be diffusion restricting, some may have contrast enhancement, some may not have enhancement, some may have diffuse enhancement. So they are in different stages of development and hence different on even the radiological characteristics. But again, that's more of a soft point. Hard point would be mainly the incomplete ring in at least one of the lesions would be more yielding. And commonly to never have a uniform diffusion restriction, at its best it would have a peripheral diffusion restriction and not uniform restriction of the whole of the cavity. So that's easy to differentiate from a brain abscess, mainly bacterial or tubercular abscess. The malignancy which can mimic the common abscesses is glioblastoma multiforme, because again this is rapid to develop, can develop in weeks, and can have a single large lesion while before it even presents, It can have a few 2 to 4 lesions as well. But I mean, commonly we see 1 or 2 larger lesions by the time the patient presents. So a typical book picture of glioblastoma would have a dirty appearance. If we find such picture, I mean, it's quite easy to diagnose. Life is easy that way. If it's a smooth ring, it's more difficult. So a typical lesion would have a ragged appearance in the wall. It would be T2 hyperintense. Nothing specific about there. Diffusion restriction would only be in the periphery, not in the center. And it would be mild restriction. It can be significant also, but mainly in the periphery. So that's again an easy way to differentiate from an abscess, a bacterial abscess, that there's no uniform restriction, because the water molecules, again, they traverse easily across the cell membranes. If we can see cystic and solid mixed components, heterogeneous components inside the cavity, that's a very good point going towards glioblastoma. Even some metastasis. At least we can say that this is a malignant lesion and not a infectious lesion. And another characteristic point, which is a very specific thing about that, is that whenever the margin is invaded, it goes into the surrounding edema as well. So if you see the bacterial or any infectious abscess, it never goes into the surrounding edema. So the contrast enhancement never crosses the rim or the capsule of the lesion. Here, the contrast enhancement goes beyond the capsule, because it means that it is invading even the surrounding parenchyma beyond the wall, because this wall is not so respected in a case of a glioblastoma. So this is the finding, this is a specific finding. And the same would be diffusion restricting as well. So this is a reasonably specific finding. We may have satellite lesions for the same logic. They are not the matted lesions like in a TB or even sometimes a bacterial abscess. They are separate satellite lesions because this infiltration going in the surrounding can form a new lesion in the vicinity. So metastasis can have a similar picture or different picture, depends on what metastasis is. Can be melanoma or, but I mean, again, they would have edema disproportionate to the size of the lesion. But I would not, I mean, emphasize on that point as well so much, because it's a soft point. Even infection can have disproportionate edema in the early and middle stage. So if we have a book picture, I think it's easy to diagnose. Sometimes we may have overlapping picture, which is a common scenario. So what next? What else can contribute? So MR spectroscopy, I'm not so sure if it can actually contribute so much. The choline peak is typical of a malignancy, but I mean, it's not so consistent finding in studies. So MR perfusion study, I think, is a reasonably promising study, promising sequence. And I mean, it's available, but it just needs expertise of the radiologist to report it. So perfusion study of the wall of the ring enhancing lesion is of use with the logic that malignancies, primary or metastasis, are highly perfused in their walls compared to the centers. So I could come across several studies which reliably differentiate the relative cerebral blood flow, RCBF, relative because it's compared with the corresponding part of the opposite hemisphere. So relative to his or her own brain with the corresponding normal side. So in case of an infection, the blood flow is in the tune of 0.9 ml per 100 gram of the tissue, compared to even, I mean, commonly more than 2 ml per hour, 2 per 100 gram of the tissue in case of a malignancy. So this study actually was done on 46 patients, and they only took single large lesions and biopsy proven, and they retrospectively try to differentiate it in patients in whom perfusion study was done. So a typical case of a GBM, dirty looking lesion, thick irregular walls, and a very typical high blood flow, more than 2 ml per 100 grams of tissue in the at least half of the wall. So this is a reliable finding, which I think at least we know when to wait for a biopsy and when not to wait and go ahead with the excision of the lesion or a biopsy. So now we come to the smaller ring enhancing lesions, less than 1 or 2 centimeters. Roughly, broadly speaking, immunocompetent, immunocompromised would have different causes. TB, of course, is common in both, but in normal healthy person with a smaller multiple lesions, we would at least think of cysticercosis, which is becoming less common, but still we see in many parts of Rajasthan and even in Gujarat, a few places. So we need to know again the pathology of the stages of development, and hence we can understand the radiology better, and we don't have to memorize the sequences. So first the vesicular stage, which is mainly a fluid stage, right? So there is a central scolex. There will be typically a fluid-filled lesion, as we all know it, and minimal edema of the cyst wall and the surrounding. So this is obviously the live scolex, which starts to degenerate in the colloid vesicular stage. And as it degenerates, the proteinaceous material accumulates in the center, hence we call it colloid. And that leads to allergy and local edema. The third stage would be more of a solidifying stage. We call it a granular nodular stage, where the edema starts reducing, but lesions start becoming more solid and eventually calcified. So calcified is very easy to detect and not so relevant later on. But more confusion is in the vesicular and the colloid and the granular nodular stage. So this lesion goes from liquid to solid, and the abscesses, including the tuberculomas, they go from solid to liquid. So it's easy to diagnose vesicular stage whenever a scolex can be seen. So every attempt should be made to show scolex in at least one of the lesions, right? When you have multiple lesions, doesn't matter. You may not be able to dissect through all the lesions, but if you can demonstrate a scolex in the single lesion, it's totally worth it for stamping the diagnosis. So because it's CSF intensity, it is very bright on T2, and it is significant attenuation on flare, which I have not shown here. This is a T2 image, but on flare, this whole fluid will be attenuated in the intensity of the CSF, and only the scolex would be seen. So it's a very handy sequence to show the scolex. T1 contrast would show the central dot of the scolex, and not so much of ring enhancement as we can see, because the edema is not so prominent. SWI, again, a very handy sequence to see the scolex, because there is soft calcification even in the vesicular stage of the NCC. And these all central dots are soft calcification. So we should ask the radiologist to specifically focus on SWI of these lesions. And if even one of the lesions can demonstrate soft calcification, it's worth it. Fiesta sequence, which is a heavy flare sequence, would obliterate the CSF intensity and show only the scolex. If there is masking of the lesion, if it is inside a CSF space like cisterns or ventricles or the subarachnoid cyst also, we would be able to see the wall clearly and the scolex clearly, because all the CSF space would be attenuated on a fiesta. So more difficult is the colloid vesicular stage, because in vesicular stage we would see the scolex by these sequences quite reliably. So difficult one is the colloid vesicular stage, where the scolex is degenerated. There is no scolex. We see only the lesion, but the lesion is more fluid still compared to what a tuberculoma or some other lesion would be. But this is more fluid, and hence T2 hyperintense would attenuate on flare. It would show a routine ring enhancement with edema, non-specific. On SW, on contrast, it would show a simple ring enhancement. Sorry, this is the flare, which would show partial attenuation because it's not totally CSF-like, but started having proteinaceous material, and hence it would be just in between attenuation, not a CSF-like space, as in the vesicular state. So nothing much to specifically comment on the colored vesicular state, and same goes for the granular nodularity. Just that the T2 hyperintensity starts reducing, flare intensity starts reducing because the lesion becomes more and more solid. So let's understand which stage of NCC is confused with which stage of tuberculoma. So in the caseating granuloma, as I said, T2 hypointensity would be there, which makes life easy because T2 hypointensity will not be found in any of the NCC stage except the calcified stage. But calcification is easy to see on SWI, which would be hard calcification. So going back, this would be a hard calcification on SWI, which is not difficult to diagnose. So in short, T2 hypointensity, if we can show in one of the lesions, it would be more of caseating granuloma stage of TB compared to NCC. In the stage of caseating granuloma with liquefaction, the lesion would be quite similar to NCC. So that's where the confusion comes mainly. The non-caseating stage would be solid enhancing, which is nodular enhancing, and caseating stage would be ring enhancing. So nothing much to again differentiate here. Diffusion weighted image, nothing much to differentiate, except that if we have mild diffusion restriction, it would go towards TB, and because NCC, no stage would have a diffusion restriction. And as we discussed, the last stage of TB, which is the caseating granuloma with liquefaction, may have mild diffusion restriction. Location, again, not much to differentiate, except when it is in the ventricle or cisternal. Of course, it's NCC. Again, my observation, and I think, I have heard a few radiologists in NIMHANS, and they also are of the view that if it is sitting on the cortical gray matter, or if it is just pial and subpial lesion, it's much more likely to be NCC. So even if there are multiple lesions, if one of the lesions is sitting on the pia or the cortical gray matter exactly, it's much more likely to be NCC than a TB. So, but it is more of their observation, and I'm not sure about the evidence. So how do we differentiate? So T2 hypointensity goes towards TB, and if we have complete suppression on flare image or a fiesta image, like a CSF intensity, we are clear that this is a frank fluid, and frank fluid does not happen in TB. It happens only in NCC, the vesicular state. And if we can, we should make every effort to see the Scolex on fiesta sequence, SWI, the soft calcification, and the flare image, which would differentiate from TB. So coming to compromised patient, the small REL, because they're compromised, we have special reason to look for some fungi, nocardia, and primary CNS lymphoma, toxoplasma, and such. So to start with, cryptococcus, cryptococoma are same as tuberculoma in their radiological appearance. It can also have basal meningitis, can also have vasculitis in the lenticulostriate vessel territory. So not much to differentiate from TB, except the fact that obviously cryptococcus is less common than TB in India. So nothing much differentiates that way, but we don't have this dilemma often because we have a CSF study which generally comes out positive because cryptol antigen is highly specific and sensitive both, and which is the ideal test. So hence we don't have much dilemma generally. One common appearance would be a soap bubble-like appearance where we have clogged cryptococcus in the dilated perivascular VR spaces around the basal ganglia. So if you have such appearance, it is specific for cryptococcus. But even otherwise, I mean, dilemma is not so much because of the cryptococcal antigen CSF. Another thing that this is primarily a meningitis, not a primary parenchymal lesion. So meningitis would commonly be there on top of these cryptococcomas. So, for example, contrasting it from toxoplasma, which would have more of a parenchymal lesion compared to the meningitis. So, as I said, it's more of parenchymal disease. Location 85% of times in toxoplasma would be basal ganglia and thalamus. Reliably, we can say it happens in immunocompromised patients. By and large, HIV being obviously the most common cause. The pathology would be more like a tubercular coagulative necrosis in the central territory, and peripheral vascular supply would be quite rich in a typical lesion of a toxoplasma. It doesn't have a capsule. So this ring enhancement is not of the capsule, but is of the peripheral vascularity. And one specific sign on a contrast image would be a central dot. I mean, the paracentral dot is an eccentric dot, which actually consists of a bunch of small vessels, not an organism. So if we can have this eccentric dots, eccentric target sign on a contrast image, this is a very specific sign for toxoplasma. Sometimes can be found. In one study, I could find 1/3 of the times. Another specific sign is the target sign on T2 image, in which there are concentrating rings of T2 hyper and hypo intensities. But I think the lesions are quite small, and anyways, it's very difficult to appreciate such concentric rings. But at least eccentric target sign, I have also seen. I'm sure people this talk have more experience than me, and they would also have seen at least once in a while eccentric target sign. So a toxoplasma is confused either with TB or with primary CNS lymphoma in patients who are HIV positive and CD4 less than 100. Primary CNS lymphoma, again common in a lifetime of a HIV patient, especially if untreated. 2 to 6% is the incidence, which is a high incidence in HIV. It's decreasing year by year because of the better treatments, but still it happens, and we all have also seen it sometimes. So the lesion can be half the times single, half the time multiple. So if there are, the corollary is that if there are multiple small lesions, it is less likely to be, if there is a single lesion, it is much more likely to be a lymphoma compared to a toxoplasma. But if multiple lesions, is not much to differentiate by the number. 95% times it happens near a CSF space, most commonly basal ganglia and periventricular, including the corpus callosum and the posterior periventricular white matter. Sometimes can be near the cortical gray matter, starting there and coming towards the medial aspect of the brain. The size sometimes is more than 4 centimeters, especially in late presentations. But the most confusing part is the early granulomas, early lymphomas starting in the basal ganglia. Those are lesions which can be easily confused with the toxoplasma. But lesions which are more than 4 centimeters in the first presentation are easy to diagnose, and more than 4 centimeters, as well as if there's a single lesion, less likely to be toxo. And they are quite aggressive. The median survival is only a few months if not treated, and hence we should not a good idea to wait for 2 weeks of empirical treatment for toxo before considering a lymphoma. That's, I think, more of a old textbook teaching when the sequences were not so advanced. But I think with the PET study, the perfusion studies, I think there should be more aggressive lookout for a lymphoma in even a suspected case vis-a-vis toxoplasma. So not much to differentiate from conventional sequences of T2 and T1 contrast. It generally is hyperintense. It shows ring enhancement rather than a solid enhancement, even in larger lesions and smaller lesions, because of central necrosis. And the central necrosis suggests the aggressiveness of the lymphoma in compromised patients. In immunocompetent patients, whenever we have lymphoma, it is not so aggressive, and there is no significant hemorrhage or necrosis in the center, and hence they are diffusely enhancing. While in compromised patients, they mostly progress with central necrosis, and only peripheral malignant cells are seen. And for the same reason, the diffusion restriction also is just peripheral, and the center is clear. In this case, this is again a dirty looking lesion with irregular walls and central clearance, peripheral enhancement on T1 contrast. On flare and even on T2, they are hyper intense centers and patchy, multiple, starting from the basal ganglia, a typical case to confuse with toxoplasma. Not much to comment on the diffusion. So a good differentiation was done on a PET scan, which showed a hot nodule in the place where there was a contrast enhancement, and which easily differentiates it from toxoplasma. So I think rather than wasting 2 weeks of empirical toxoplasma treatment, in cases where we are not sure the toxoplasma antigen is negative, for example, we should always go for PET, SPECT, or a perfusion study. But I think the radiologists are more conversant with the PET study. So I think PET can be a good choice in this case. So as the jargon goes, that lymphoma on these studies is hot and toxo is not. So to end my talk, before that, I would just mention a brief case where this advanced imaging could come to good use to me. I had a young, healthy 20-year-old girl who had first-time seizures, and there was no clue in the systemic findings. The CSF was unyielding. There was no significant clue to diagnose. She was already reported as having early glioblastoma, and the father was very worried. She had just got married, in fact, and 1 month of marriage, so they were very worried about the cause and wanted to get operated. And for that same reason, they had come to me. So the lesion was, this was a solid enhancing lesion, not a ring enhancing lesion. And the corresponding place of the lesion was iso-intense on T2. So again, not much to take away from these sequences. There was no significant restriction on DWI, and same thing, no contribution from SWI as well. So this is a typical case where we are stuck, and this is not, I mean, a textbook picture suggesting any single cause. In early stage, it can be nodal enhancing, then can become ring enhancing and show other characteristics of the cause. But at least in the early stage, there was not a clear picture. So would we go for a biopsy or wait and give empirical ATT or do something else? So I just took a chance and ordered the MR perfusion study of the periphery of this lesion. And to my good surprise, I could find that where this lesion was there, the same place was significantly hypoperfusing on MR perfusion study, which at least suggests this is a non-malignant lesion. That's all we can interpret. We can't, of course, know the cause, but it's a non-malignant lesion, which can be reasonably, we can be assured by the perfusion study of the wall of the lesion. And also I could find tree in bud appearance. I mean, obviously the radiologist diagnosed and pointed out. I mean, we would not be so good in seeing the chest scans, but tree in bud pattern, and there were matted lymph nodes in the paratracheal region, multiple ones in several places, and the endobronchial biopsy came strongly positive for tuberculosis, and the girl could be at least saved for the day for undergoing a surgery. So sometimes, I mean, these images can be of use. So I would end it with a few messages that if we have a textbook-like picture, if all sequences of the MRI go towards a single etiological diagnosis, then it makes more sense to commit to the radiological diagnosis. Otherwise, if everything shows in a chaotic way, non-concurrent findings, we cannot be sure, and radiology has its limitation as well. We should try to seek specific MRI findings, like in fungi, like in NCC, sometimes in TB and lymphomas, right? Toxoplasma. So we should remember and try and find specific MRI features in relevant sequences, and we can ask the radiologist also to order and focus on these sequences to see the specific etiology. We should mainly try to just categorize. We would not get the final answer always about the type of organism or the subtype of the tumor, right? But at least we can know the basic category of what type of lesion it is from the MRI. So we can say this is an abscess. We can also say it is a fungal abscess or a non-fungal abscess. TB versus NCC can generally be sorted out. Malignant versus non-malignant lesion, this is at least what we can commit. Not always which type of malignancy, difficult to say, but at least malignant or non-malignant, so that to biopsy or not can be answered. And a demyelination lesion generally should not be difficult using the above sequences. And lastly, only Ramdev Baba's drugs are 100% treating. I mean, at least imaging is not a wonder test. In many diseases, it has its own limitations. We should understand where it is helpful, where it is not, and that's all I would say. Yeah, thank you.
Thank you, Sagar. Wonderful talk.
Right. Thank you, boss.
Yes.